This innovation is not a cure for cancer. It won't double your ejection fraction. It's not the next big breakthrough. It is a low-cost, simple improvement to our current practice that makes the ICU nurse's life a bit easier when taking care of patients who require hemodynamic monitoring. It eliminates two common problems nurses have with these lines. The first problem, over time, fluid in the drip chamber rises to a level in which you can no longer visualize flow. The sole purpose of the drip chamber is to allow for visualization of flow with a fast flush. Fast flushes are done to ensure patency and functionality of the line. Often this is the first step when troubleshooting abnormal vital signs. How much of a problem is this? In a survey sent to ICU nurses, 97% said this happens at least sometimes. Nearly half said always or frequently. It's unclear exactly how many nurses attempt to resolve this problem or just deal with the inconvenience. If they do resolve the problem, they open the line, which creates an opportunity for microorganisms to enter, and this takes time away from other nursing duties. The second problem with our current practice is air can get into the line. This can happen when the drip chamber is not vertical. It happens frequently when moving patients and in the transport world. In the inpatient setting, it can happen when patients go for procedures such as a CT scan or angiography. Frequently, there's not room for the IV poles, and the IV bags are tossed around and frequently laid on the patients. These bubbles, once in the line, can alter pressure readings. This is important because clinical decisions and vasoactive drugs are titrated based on these readings. If a nurse wants to get rid of the bubbles, it takes time away from the nurse and creates a port of entry again for the microorganisms. These bubbles can also make patients and their family nervous. I don't want to overstate the risk for air embolism. However, there have been case studies of embolism causing stroke or seizures from arterial line. This is more likely in children because of the smaller distance for air to travel. With newer technologies such as the intra-aortic balloon pump, catheter ports are closer to vital organs. The intra-aortic balloon pump is centimeters from the carotid arteries and not too far from the coronaries. I don't want to harp on the air embolism risk. However, patients with an intra-aortic balloon pump do have a 2% increased risk in stroke. Patients who have an embolism caused by air would be difficult to diagnose with CT. Often, by the time a CT is done, the air would have dissipated. I changed my practice after transporting a patient with a balloon pump to a unit who later had a stroke hours after I dropped him off. Whether the stroke was caused by me and air in the line will never be known. However, I now prime all my lines without any air in the system. I do this by inverting the drip chamber in the bag, allowing it to fill completely with fluid, and then priming my line. The problem with this is I can no longer see fluid flowing into the patient, and I have to assume the line is working. While there are methods and waveforms to look for on the monitor that signify flow, there is nothing like seeing actual flow moving. Most critical care transport nurses prime their lines that way. 41% of inpatient nurses do as well. The solution to the problems of not being able to visualize flow and the other problems created by air entry into the line, nursing time, infection opportunities, risk of air embolism is to have a method that allows you to see fluid movement in a line that contains only fluid, no air. This innovation does that, and it does that with minimal cost. Here the drip chamber is primed without air, leaving only fluid in the line. You see, when fast flushes are applied, the paddle wheel will move. You can lay this in any orientation. It even operates safely upside down. This is the most powerful slide of the presentation. I asked ICU nurses if a product like this would be beneficial in their practice. 67% said it would be very beneficial, 30% somewhat beneficial. In summary, this gets rid of all the air in the line. You can still see fast flush and fluid movement, fewer false pressure readings, lowered infection risk. You can prime the line faster initially. It's less time removing bubbles from the line, less chance of an air embolism, and it creates other visualization alternatives. For example, a paddle wheel can be developed for night vision. There can be different color choices based on device. You can even create a paddle wheel that is activated by fluid and will change color in 48 or 72 hours, signaling the nurse to change their IV bag. The next step is to get working, functioning units into the ICU and let nurses trial them. Only then can we compare to see if there is any clinical benefit. Regardless, I think ICU nurses will welcome the change and appreciate the change in their daily routine. The patent is filed. Innovations can give more detail on the patent. This is not my area of expertise, but based on the conversations I've had, it seems easy to do with low cost. Nor will this take a lot of time or research to bring to the market. Manufacture of the drip chamber will add approximately 7 cents, and initial tooling will range from $20,000 to $120,000 to get everything finalized. Target markets in order of likelihood. I think all of critical care transport can use this. I think there's an opportunity in the pediatric ICU, in patients with intra-aortic balloon pumps or other high-risk catheters near the brain or heart. And I see no reason this shouldn't be used in all patients with hemodynamic monitoring. Why have potential problems when it costs so little to prevent these? On the peripheral IV side, this can be used, the technology can be used for fluid boluses on any patient who is expected to move multiple times or in non-typical areas. EMS, helicopter EMS, military, things of that nature. In the inpatient setting, picture the unstable patient who's about to go for multiple procedures. You can hook a standard IV line, eliminate all the air, and you can give fluid boluses without worrying about air getting into the line. In conclusion, although this may take pennies more to make, because a company can offer this exclusive improvement, they will be able to sell much higher volumes, leading to higher overall profits.